What's up, guys? Welcome back to my YouTube channel. Today we're going to be doing another part of the fellowship subspecialty series. Today we're going to be talking about neuroradiology and its fellowship. So let's get started. Alright guys, so welcome back to another episode on the fellowship series. I'm glad you're enjoying this series. I've gotten a lot of feedback on the body and MSK videos so far. If you haven't seen them, go check them out. I also have an earlier video about interventional radiology, so this video will be focused on the neuro fellowship and its subspecialty and what it has to offer. So like always, if you enjoy the content, please like and subscribe to the channel, as there's many more video topics that you've requested both on Instagram and on YouTube. If you don't follow me already, make sure you do so at Daher Radiology on Instagram. And again, leave suggestions for future videos. So without further ado, let's get started on today's video. We're going to be talking about neuroradiology as a fellowship. We're going to talk about the different types of imaging that are in neuroradiology. We're going to talk about the procedures and the types of things that are done within the field of neuroradiology. We're going to do a little bit of pros and cons, as we always do. We're going to talk a little bit about billing estimates, and then the overall field in general. So let's get started. So in neuroradiology, this field is quite subspecialized. Obviously, you're focusing on the neurological system. So what that means is usually you're focusing on the brain, the head, neck, spine. That's classically what the neuro subspecialty involves. So you do a bunch of these rotations in your residency. So everyone gets exposure to neuroradiology. There is a subsect of neurointerventional radiology, which I'll maybe touch about a little bit at the end of the video, but we're going to focus on the diagnostic neuroradiology fellowship side of things today. So we'll start off by talking about what kinds of modalities are used in the neuroradiology subspecialty. As always, there's a wide variety of modalities, so anything from x-rays, so lateral neck views, open odontoid views for fracture. You're looking at skull radiographs. PEDS has a whole bunch of subselect reasons for using radiographs. And then you have your CT scans. So the CT is really the bulk of the imaging for acute brain stuff. So any type of fall or trauma injury to the head, you're going to get a non-contrast CT scan of the brain, and that's going to be really good for seeing acute findings such as intracranial hemorrhages, subdural hematomas, extradural stuff. You're going to be looking for fractures. You could also, in the acute forms of stroke and in chronic forms of stroke, but more importantly, when you're trying to deal with an acute stroke, you can do a CT of the head where it'll show you changes in the gray-white differentiation, potentially seeing an MCA hyperdense sign. And then furthermore, in the CT realm, you can do angiography, where you're going to do insertion of IV contrast, and you're going to be able to see the vessels of the neck and of the brain, especially in stroke imaging. You want to know if there's a thrombus in one of the vessels, and that'll change the guidance for the stroke management, whether or not EVT is performed, which is endovascular therapy. So basically, neurointerventional radiology is the subsequent intervention that happens after stroke is identified, if it's within a time frame, as well as if it's retrievable clot that they can go in through the neck vessels and up into the brain vessels. As well, there's CT perfusion. Perfusion allows for the assessment of blood flow and blood volume to areas of the brain, especially in a stroke. This can be very, very sensitive at figuring out where the blood abnormalities are, if there's a mismatch, if there's penumbra that is within the brain that is salvageable. So it can tell you a lot of dynamic information, which is pretty cool to a person who's had stroke. And it's a very fundamental part of the stroke protocol and code strokes that happen at the hospital. So you play a very large part of that. CT of the neck is also a super important modality. So within the neck imaging, you give contrast and you can see a lot of things that are hidden within spaces in the neck. The neck is all about anatomy, but when you're examining someone on physical exam, it's very hard to determine what is going on from the outside. Not a lot of blood work kind of describes things in the neck unless you just have elevated white blood cells to maybe indicate infection. But other than that, you're trying to figure out what's happening in the deep spaces of the neck. You do a CT neck with contrast. It'll show you abscesses. It'll show you stones. It'll show you if there's lymphadenopathy. It'll show you if there's a mass. There's a whole bunch of utility to using that, especially on call. CT necks are super important to subspecialties like ENT and maxillofacial surgery, and really it can play quite a vital role in making a diagnosis in the acute and long-term setting. You also are dealing with the spine. So in a trauma C-spine, a lot of the times for the physicians and trauma surgeons to clear a person's C-spine, they get C-spine imaging, which is really sensitive for seeing fractures. You have your classic fractures that you learn in medical school, such as your odontoid fractures, your hangman's fractures, clay shoveler's fracture, all these eponymed names that you can identify and see quite often actually on call. So that's super useful and super important imaging for acute settings. You also have your CT heads and face. So these, can describe fractures of the facial bones, for example. So when you're dealing with orbital blowout fractures, when you're dealing with Lafore fractures, these are all fracture patterns that people see within the emergency department that are specific types of fractures and are helpful for identifying what's stable, what's unstable. Of course, identifying them in the first place, is the most important part. So you play a pivotal role in that sense as well. You also do orbital imaging, so it's a CT scan of the orbits. It's really helpful for looking at proptosis, things like infections. So you can have preseptal and postseptal cellulitis and infection. Essentially, you're looking for things that are going to change management for the patient. So when you're dealing with infection that's only on the outside of the orbit, it's probably managed more conservatively, whereas if things are within the orbit and they potentially may affect the intracranial aspects of the patient, then you're going to be more aggressive in your management. And then there's also things like orbital rupture or globe rupture in a trauma, things like extraocular muscle involvements. You have a whole variety of diseases that affect the extraocular muscles, like IgG4. To get into the specifics, it would probably take a whole nother video by itself, but orbital CT imaging is also something that's done quite frequently and very helpful. You also have CT of the sinuses. So sinus CT is not as more of a chronic thing where you're dealing with polyps or thickened mucosa of the sinuses, this is really helpful for preoperative planning. You're looking for anatomical variants that the ENT surgeon would need to know prior to going in, so that they don't accidentally nick a nerve that's close by. So these are all really important and really vital in the patient's care. So other than CT, CT is also used for the spine in the thoracic and lumbar areas for vertebral fractures, compression fractures, degenerative changes, spondylolysis, always have trouble saying it. You also have, spondylitic changes. Ankylosing spondylitis affects the SI joint. So a whole variety of uses in the CT world in neuro. You also have MR. So MR is really important, especially for the brain. The brain is a pretty difficult organ to see on CT. You can make out quite a bit on CT, and it's therefore very helpful and useful in acute phase of stroke and all these things. But when you're looking for white matter changes, when you're looking for strokes that aren't detected on CT, when you're looking for the whole gambit of brain tumors, primary, secondary, diseases that affect the myelin sheath of the nervous system, these are all MR based findings that are more specific and more helpful. So, when you're dealing with multiple sclerosis, for example, when you're trying to determine what kind of tumor that was found on CT is seen on MR, it has signal characteristics, it enhances, it doesn't. These are all helpful findings to help better characterize things that are seen on CT. MR, also the spine in the acute setting, super helpful to seeing cauda equina. You're trying to see if there's compression in the spinal cord and spinal cord changes, if there's ligamentous injuries and fractures that have been identified on CT as well. These are all important things to know for the surgeon, especially if they're going in there and need to repair. So all in all, the gambit of modalities in neuro is quite vast and is super helpful for the clinicians, and plays a pivotal role in the patient's care. So the next thing we're going to talk about is the procedures that are seen in neuroradiology. So procedures are broad, and they can overlap sometimes with other procedures such as in MSK, but some of the common procedures are parafacet, facet injections. You're dealing with, sometimes within the spine you can get these cysts, Tarlov cysts, or parafacet cysts. They can cause compression of nerves and pain, and they can need to be popped. So there's that kind of procedure. You can have procedures that involve neurointerventional radiology, such as clot removal. In acute strokes, we talked a little bit about that earlier, but it's a whole branch of, subspecialty where you do interventional on top of your neuroradiology fellowship, and you get into some of that detailed stuff, and maybe we'll do a future video about it if people are interested. But for now, we'll just kind of leave it simple as that. We do vertebroplasty, so sometimes when you have a compression fracture of the vertebral body, there is a needle that's put into the vertebral body and injected some cement, basically, that expands the actual vertebral body and tries to get it back to its shape and help with the support of the axial loading that's happening on the spinal cord. So very helpful for patients with compression fractures for that reason. A lot of nerve blocks. So obviously in neurology, there's a lot of issues with nerves, peripheral nerves, central nerves, and in neuro radiology, in the procedures, you can actually do nerve blocks in certain areas that will hopefully relieve patients' pain. Sometimes this can be diagnostic and therapeutic. So if the ordering physician, let's say the family doc, it thinks that there's pudendal nerve innervation problem, then the radiologist will put in something that will help eliminate, let's say not eliminate, but put an anesthetic or a local anesthetic in that area. It's both diagnostic. If the patient's finding relief with that, then they know that, okay, yes, that is the nerve of question, and then therapeutic in that it is actually relieving the patient's symptoms, and could be performed on a more common, or I guess a more frequent basis, where an injection of corticosteroid or anesthetic may be helpful for the patient in the long run. Multiple corticosteroid injections can be performed in the spine, and patients with degenerative changes, obviously, or fractures and etc. Like, these are things that can help with joint spaces that are small, that are degenerated, and it just works like any other injection in your knee and your hip, for example, that helps with the arthritis that's set in there. All right, so the pros and cons of neuroradiology are broad, and I think some of the pros I've already mentioned in the video. I think that it's a super cool subselect specialty that is super cutting edge. A lot of new and exciting forms of EVT therapy where you're doing neurointerventional radiology are happening, and a lot of innovative stroke technology, perfusion, things that are really helpful in helping the patients in the acute setting really make a difference in the patient's lives. Stroke would not be the same without imaging, and so it plays a crucial part in code strokes, and so that's come quite a long way in today's therapy for strokes themselves. Helps a lot with the dictation of whether or not thrombolysis is used, etc., etc. But that's a pretty cool part of the subspecialty, is that you're really making a difference in those acute settings, especially in fractures and strokes and bleeds and stuff like that. Other pros of the subspecialty is that when you do it, you can kind of focus on neuro. There's a lot of things to know in neuro, don't get me wrong, but most academic centers, at least, that do neuro kind of focus on neuro. That's not true for community-based centers because they're doing everything. So if you're a neuro trained person, you may be asked to do the complicated neuro cases, but you're still going to be doing a variety of things. But if you were to practice in an academic center, you may be quite a bit heavier on the neuro aspect of things and may not need to worry about reading body scans, for example, but that really depends on the job that you're doing. And on that note, basically a con of it is that potentially you are someone who likes all the different types of body imaging and MSK imaging, and you don't really want to just narrow yourself into a field if you were to do academic radiology. Now, that obviously can be solved picking the type of job that you want, but neuro can be quite sub-selective and sometimes can be a problem if you are someone who is a generalist and likes to do all things. Another pro of neuroradiology is that it bills quite a bit. MR is very heavy in the neuro world, as you would imagine, with brain imaging and spine imaging. A lot of the MR time is booked for neuro cases, so that really tells you that it is quite a high MR producing field of medicine. And in Canada, at least, or in Ontario, neuro really tends to bill the highest in terms of the subspecialties, and it's simply because of the fact that there is so much MR involved in the everyday work of neuroradiologists. That being said, the billing, I've talked about this in a little bit in my previous videos, it really depends where you're working and how things are split. If you were, doing things all on your own, I guess if you were just billing what you killed or eat what you kill or whatever, essentially you would be billing quite a high amount. But I don't really think that there's many practices out there that are, solo neuro billing that are, reasonable. And I think that for the most part that people are in groups so that they can split the work evenly. There are still, x-rays and CTs that need to be read that are non-neuro, and if you're part of that kind of group, if you want to focus on your neuro billings, it's not really fair that the other people who are reading x-rays and CTs are billing less than you, and for that reason they maybe not should not be making less than you. So and a lot of the times they'll split the billings for that reason based on the amount of work that's done and the amount of call that the person's doing. So just because you're a neuro or a part of the highest billing codes, then, or not codes, but the volume of MR doesn't necessarily mean that you're working any harder than anyone else. So the billing game, it is valuable to have that, but at the same time is most groups understand that it's a split kind of pool of things that people need to be agreeing on. And then finally, I would say that neuroradiology is quite a vast and interesting field of medicine. It plays quite a pivotal role, as I mentioned, in acute setting and chronic settings. The volume is increasing as the imaging becomes better and better. The technology that's cutting edge within neuro is insane, and I think will only get better. The field itself is becoming more and more competitive. It is difficult, though, to be a neuroradiologist who is only diagnostic or even interventional, because the advent of stroke is becoming more and more popular with imaging. So this means that call is quite heavy. A lot of emergent imaging happens overnight, of course, and you are responsible at any hour of the night for those things. If you're doing just diagnostic, of course, you can probably read that from home and then go back to bed, whatever. But if you're interventional, you're likely getting called into the hospital on most call shifts, and that's very variable. But you can't really say, oh, this can wait till the morning, etc. But so that really plays a tough role in your decision and what your lifestyle choices would be for the future, if that's what you're after. So all in all, I hope this video was helpful, a little bit of an overview of neuroradiology. It's a cool field. Really think it's been advancing quite a bit, and a lot of people are looking forward to what it has to offer in the future. If you like this video, let me know in the comments. Give me a like, give me a subscribe. If you want more, please suggest things in the comment section. I can only make videos if I know what you guys want, so keep me posted, and we'll see you in the next one. Peace.